Good morning, everybody. It's my pleasure, in fact, to chair this session with Dr. Sadiq and to present our first speaker, who doesn't need any introduction. He's a well-known internationally. He's a pediatric nephrologist. He's Dr. Bassam Saeed. He was ex-president of the MESOT, and he was the founder of the fellowship program in the MESOT. He's also the co-chair of the ISN Middle East board for the time being, and he's going to cover a very interesting topic, which is related to cell therapy and the stem cells and all the latest about this topic. Please welcome Dr. Bassam.
So good morning, everyone. Thank you, Dr. Muna. First of all, I would like to thank the organizer of this meeting for inviting me. It's a great honor and pleasure for me to be part of this very important meeting. How to change this? Okay. So my talk today will be about cell therapy and tissue engineering in renal disease, stem cell as a new trend. Okay. So as you know, we have two sectors in kidney disease which are somehow different. Acute renal failure and chronic kidney disease. Regenerative medicine for acute renal failure is completely different because the kidney has the potential to regenerate itself if the damage is not too severe and the kidney structure remain intact. The opposite, for chronic kidney disease, the irreversible kidney damage, self-renewal is totally lost. So regenerative medicine here will involve the establishment of functional whole kidney de novo. As I said, here we have two parts, acute kidney injury and chronic kidney disease. What are the regenerative medicine for acute kidney injury? We have several strategies. First, depending on cellular effect, we will come across it, and paracrine effect. While in chronic kidney disease, we have completely different strategy. So first, as you all hear about the renal assist device, I think we are still far from having it implemented. And we can replace synthetic functions such as erythropoietin. This is also some way to regenerate function. And of course, the most complicated one is nephrogenesis. Nephrogenesis depends on several acts. First, kidney derived from metanephric primordia, we will come across later on, or seeding synthetic matrix, or seeding organ scaffold. So we all hear about this implantable renal assist device. What about kidney derived from metanephric primordia? Metanephric primordia means fetal kidney. So developing renal primordia from animal embryos transplanted into another animal with kidney disease via xenotransplantation, these transplants undergo renal organogenesis and become vascularized by blood vessel of host origin. And this is very important. If the blood vessel will be from host origin, this will prevent from having acute rejection, etc., etc. And this graft exhibit excretory function and generate functional nephrons when transplanted into animals with severe renal disease. For example, rat to mouse or pig to rodent, and hopefully in the future from animal to human being. What about the paracrine effect? This is one of the strategies for cell therapy. You know, some of specialized donor cell act to stimulate the patient cells to repair the diseased tissue. So we depend on cell action. How these cells act? They act because the donor cell secrete factors, and these factors signal the patient cells to change their behavior. Research areas, there are several areas. First of all, as I said, acute kidney injury and chronic kidney disease. First of all, we have to differentiate what is called pluripotent stem cell into renal lineage. So we have pluripotent stem cell and we have renal stem cell. So we have to generate renal stem cell from pluripotent stem cell. This is the first step. Second, we have to identify and isolate this renal stem cell. And third part is to inject or transplant these renal stem cells. One of the research areas is, of course, vascular and glomerular diseases, very long topic, and immunology of transplantation, especially with respect to immunomodulation of mesenchymal stem cell. We'll talk later on about mesenchymal stem cell. This is a unique cells, which is a natural body defense mechanism. One of the research area, of course, it is autosomal dominant polycystic kidney, because polycystic kidney, you know, is a frequent disease, common disease. But first of all, we have to understand the mechanism involved in the pathogenesis of renal polycystic to aid the healing process. Now, let's talk about mesenchymal stem cell. This is a unique immunomodulatory cells. The unique properties of these cells make them an invaluable cell type. It's very important, especially with respect to the future of tissue engineering, for the repair of tissue and organ damage caused by chronic inflammation or autoimmune disease. So we have so many diseases caused by inflammation or autoimmune. So most of these diseases can be find a way to be solved by injecting this mesenchymal stem cell. So these cells hold great promise in the treatment of immune disorders, for example, graft versus host disease or allergic disorders. However, there remain many challenges to overcome before their widespread clinical application. There are different regeneration strategies being investigated. First, depending on cell-based approach. We have stem cell transplantation, stem cell conditioned medium, and cell differentiation. I will give you one example. If we look at this patient with oxidative stress disorder, we have first to identify bone marrow cells and pluripotent stem cell, and isolate establishment of renal stem cell, and then culturing this renal stem cell into growing embryos, the kidney of the embryos, and then later on we transplant this kidney. This is very promising strategy. Another strategy, which is development of approach, depends on metanephric transplantation, as I mentioned earlier, a xenobiotic kidney organogenesis. This is very complicated and deserve a whole session, and blastocyte complementation. I would like here to mention about this strategy, which is blastocyte complementation, because it is really very interesting. The injection of a human pluripotent stem cell into animal blastocyte provides a possible strategy of growing a human organ in animal host. Can you imagine? We can grow a human organ into animal host. The other strategy is tissue engineering. We'll come across later on, especially with respect to decellularized, recellularized technology, and bioartificial kidney, which is our dream. But it is a possibility, not only a dream. We will talk about later. Let me talk a little bit about Harvard Stem Cell Institute. Harvard Stem Cell Institute, as you can see here, there are 1,000 scientists working over there. Can you imagine? 1,000 scientists working in Harvard Stem Cell Institute. They have several programs, as you can see here, blood program, cancer program, cardiovascular program, diabetes program, and kidney program. So kidney program, the Harvard Stem Cell Institute is developing new therapies to repair kidney damage, reducing the need for dialysis and transplantation. This is our dream, to reduce the need for dialysis and transplantation. They have short-term plan, medium-term plan, and long-term plan. Let's have a look on their short-term plan. Short-term plan depends on mesenchymal stem cell, this body natural defense against kidney damage. It is found in the bone marrow, and this cell protect the kidney from injury. So they are very important for us. Harvard Stem Cell Institute have identified protein candidate secreted from these mesenchymal stem cells. So when we identify this protein can be used in order to for kidney repair. In another approach, these mesenchymal stem cells are being incorporated into miniature dialysis. So the miniature dialysis machine will expose the patient blood to these cells, allowing pro-repair protein to be delivered directly to the kidney. Their medium-term plan, already we have in the Harvard Institute of Stem Cell have identified the most susceptible cell type in the kidney, which are, there are several cell types during diabetes. So already we know the kidney cell type that are most susceptible. So Harvard Stem Cell Institute now plan to target these cells with a new drug. So we are looking for target for new drugs. One of the target also is to identify genes that change in diabetes, in diabetic kidney cells. If we identify these genes, then we can identify compounds that slow or stop the destructive gene expression. A drug for disease-related kidney damage has the potential to eliminate the need for dialysis. So first we have identified the cells which are most susceptible to injury, then identifying the gene, and later on the plan is to identify a compound that modifies this gene expression. The long-term plan, of course, is an artificial kidney using stem cell and nanotechnology. This is strategies in animal for kidney repair after injury with stem cell. So we inject stem cell into animals who have kidney injury using stem cell. So renal stem cell, either renal stem cell or extrarenal stem cell. So by using renal stem cell, these stem cells contribute to kidney regeneration via either engraftment into damaged tubule and differentiate into tubular cells, normal tubular cells, or creation of a new nephron, which is more complicated and more effective. So neonephrogenesis, this is, we call it neonephrogenesis, in the new tubule originate from stem cell. Or injecting extrarenal stem cell like hematopoietic stem cell or mesenchymal stem cell or endothelial progenitor cells. These cells assist kidney repair through either different paracrine effect we talk about, or restoration of the damaged microvasculature by hematopoietic stem cell, or surviving tubular cells to proliferate and reconstitute a functional tubule. Very interesting. Now, this is in human. This is a very interesting study published in Experimental and Toxicologic Pathology. It is about the mesenchymal stem cell conditioned medium that accelerate regeneration of a human renal proximal tubule epithelial cell after gentamicin toxicity. You know, this scenario happened frequently, gentamicin toxicity. What to do with those patients? Using injection of mesenchymal stem cell conditioned medium. The conclusion of this study was that the high dose of gentamicin, of course, caused an increase in cell death, and proximal tubular epithelial cell exposed to high dose gentamicin for 24 hours, followed by a human mesenchymal stem cell conditioned medium recovery, show an increase in cell migration and cell transformation, so cell recovery. So how can we explain this capability of these unique cells, mesenchymal stem cells? One of the things that it is very important, especially the presence of FOXP3 positive regulatory T cells. Regulatory T cells, or Treg, will be stimulated after the injection of a bone marrow-derived mesenchymal stem cell. So these Treg cells will contain this FOXP3. What is FOXP3? This is transcription factor expressed in Treg cells. And FOXP3 appear to mediate immune surveillance. The presence of FOXP3 discriminated harmless from injurious infiltrates. Absence of FOXP3 is considered a histopathologic hallmark of nephropathy. That's the reason why when we inject mesenchymal stem cell after skin transplantation, for example, we notice the presence of Treg positive FOXP3. This is back to monkey. This is a study about intrarenal arterial injection of autologous bone marrow mesenchymal stromal cell ameliorate cisplatin-induced acute kidney injury in a monkey model. The summary of this study that this is the first report of intrarenal arterial autologous transplantation of mesenchymal stem cell in the monkey, resulting in a successful engraftment into tubule and glomerular structure after acute kidney injury. Renal recovery of monkey after cell transplantation. So the injection of mesenchymal stem cell has resulted in recovery of monkey after cell transplantation in monkey model. So it did not repair, this mesenchymal stem cell did not repair kidney parenchyma, but ameliorate the renal function. This is the same study published later on as a follow-up of the first one, 1 year later, after, as you can see here, 6 months and 9 months after the injection of mesenchymal stem cells for monkey who were injected with cisplatin. We notice here, after 7 to 9 months, that, and the most interesting point in this study that there were, it is controlled study. There were 2 groups of monkey. The first group received mesenchymal stem cell, the other group did not receive. And both they have cisplatin-induced nephropathy. So histopathological scores significantly decreased at 9 months after cisplatin injection in the cell transplanted group compared with the control group. And there were decreased hyaline cast and fibrosis score at 9 months in the cell transplanted group compared with the vehicle. So mesenchymal stem cell delay progression of chronic kidney disease in preventive model rather than established, because once the interstitial fibrosis established, there is no way. So there are not any recovery after cell transplantation in established interstitial fibrosis. What about patients with autosomal dominant polycystic kidney disease? Interestingly enough, mesenchymal stem cell also exhibit enhanced renotrophic functions. But first of all, we have to make sure to assess the safety and tolerability of mesenchymal stem cell function in autosomal polycystic kidney patients, and this may open the way for new therapy for patients with polycystic kidney. This is a study that estimated the safety and tolerability in 6 patients. The summary was that EGFR changes in autosomal dominant polycystic kidney patients from 1 year prior to mesenchymal cell infusion up to 12 months after the injection. This trial demonstrated the safety and tolerability. So already we know it is safe and tolerable. However, bone marrow-derived mesenchymal stem cell efficacy in patients with autosomal dominant polycystic kidney disease should be reinvestigated in a randomized control trial at a larger population in terms of efficacy. So now, so far, we are speaking only about tolerability and safety, but efficacy need further research, and especially randomized control trials. What about patients with membranous nephropathy? In membranous nephropathy, the main issue is podocyte. So we need to generate a functional podocyte from induced pluripotent stem cell. So in mouse, the experience has resulted in that transplantation of mouse-induced pluripotent stem cell-derived podocyte in mouse model of membranous nephropathy, it attenuates proteinuria. That is very good. As you can see here, proteinuria decreased. So what about the immunological aspect of mesenchymal stem cell to induce immune tolerance? How can we explain that these unique cells, mesenchymal stem cell, has the potential to induce immune tolerance and immune modulation? The way to do it, we have to look at different T cells, especially 2 kinds of T cells, T helper and T reg, because we know already that they are working almost opposite. T helper lymphocytes, including Th1 and Th17, they are known to be cellular mediators of inflammation. So we need these kind of cells to be calm and sleeping, because otherwise we have inflammation. On the other side, Treg cells are a mediator of immune modulatory. So we need these cells. So the first type, T helper, we need them to sleep, and we need to activate Treg. So after the injection of a human mesenchymal stem cell, after skin transplantation, we did the study to look at these two kinds of T cells by protein level and mRNA level. This is two ways of studying this point. We noticed that, very interestingly, that the percentage of Th1 and Th17 were decreased, and this is very good, after bone marrow-derived stem cell transplantation. And the percentage of Treg was increased, and this is also good. This is what we want exactly. As you can see here, in protein level, so in this study, they have evaluated this effect into two ways, protein level and mRNA level. In protein level, we can see here up that Treg cells increased in those who received adipose-derived mesenchymal stem cell or bone marrow-derived mesenchymal stem cell, while those who did not receive Treg cell remain low. On the opposite, for Th1, T helper 1, and T helper 17, those who were not transplanted with mesenchymal stem cell, the Th1 and Th17 has increased after the transplantation of this, after skin transplantation, while those who were on, after receiving mesenchymal stem cell, they have decreased Th1 and Th17. This is mRNA level, the same result. And as you can see here, the redness of skin after skin transplantation. The presence of redness down, as you can see here. Okay, I'm finishing. The presence of redness indicates the presence of inflammation, while those who received autosomal dominant, adipose-derived mesenchymal stem cell or bone marrow-derived mesenchymal stem cell, there is no redness, so there is no inflammation. Now, so the conclusion was there is preclinical progress being made in the development of cell-based approach to the treatment of acute kidney injury. Either cells as modulator of inflammation and fibrosis or cell-based products that stimulate regeneration. However, in chronic kidney disease, this doesn't function. We need a functional whole kidney de novo. So what is the putative future image of end-stage kidney disease? Recent advances has shown several facts regarding the putative future of those patients with end-stage kidney disease. There are some approach, several approach we don't have time to go through. We will mention just about decellularized, extracellularized. So the use of decellularized extracellular matrix scaffold to help repair damaged or injured tissue has emerged as a promising approach in the field of renal regeneration. This is a way to create scaffold. So we remove cells, decellularize, and then we recellularize this scaffold. Decellularized kidney scaffold are able to act as inductive template for functional organ recovery, allowing the injured area to recellularize with autologous stem cell or differentiated cells. This is very long protocol. This is a perfusion protocol in order to remove the cells, to decellularize the cells. Successful decellularized monkey kidney by applying perfusion followed by quantitative and qualitative analysis. Why we do this analysis after decellularization? In order to confirm cellular removal and the integrity of extracellular matrix architecture and integrity of and patency of vascular network. This is a different, sorry, how to go back. So, I'm sorry, huh? Oh my God. So this is a very interesting way, which is partial transplantation. This is the last part of my talk, partial transplantation. As you can see here, the kidney from monkey, we decellularize this kidney, so it become white, quite white. And then we cut part of it, and we transplanted into another animal with kidney disease. We call it partial transplantation. And then this part, which is decellularized, will be again recellularized with the host cells. And this is very important, that with host cells. And this is a way to make sure of that the decellularization was intact and complete. I don't know what is enough. Summary. So partial transplantation established an effective cell seeding method for repopulation of acellular kidney in borderline with renal cells coming from the host kidney. This is very important. Histological analysis confirmed increase in renal size, this is number one, and regeneration in borderline after 27 months of partial transplantation. Sonography and CT scan image showed a significant recovery of renal function after partial transplantation. So this result have offered new hope, partial transplantation. But further research, of course, is required in order to turn this observation into clinical achievement. Thank you very much.
Thank you, Bassam, for this excellent review of the topic. I know it's a long subject and needs more time, but we'll have the question at the end. Okay, thank you.
Okay, so now I have the pleasure